Management of vulval conditions. Introduction. Vulval disorders represent a disparate group of conditions with a variety of causes affecting a particular anatomical site and may affect women of any age. This guideline offers recommendations on the diagnostic tests and treatment regimens needed for the effective management of the following vulval conditions: vulval lichen sclerosus, vulval lichen planus, vulval eczema, vulval lichen simplex, vulval psoriasis, vulval intraepithelial neoplasia, and vulval pain syndromes. It is aimed primarily at people aged 16 years or older presenting to genitourinary medicine clinics. Care of patients with vulval conditions is best managed by a multidisciplinary approach. General advice for all vulval conditions: avoid contact with soap, shampoo, and bubble bath. Simple emollients can be used as a soap substitute and general moisturizer. Avoid tight-fitting garments which may irritate the area. Avoid use of spermicidally lubricated condoms. Patients should be given a detailed explanation of their condition with particular emphasis on any long-term implications for the health of themselves and their partner or partners. This should be reinforced by giving them clear and accurate written information. The patient's GP should be informed. STI or sexually transmitted infection screening should be considered in all patients and vulvovaginal candidiasis excluded if the patient presents with vulval itch. All patients should be assessed for sexual dysfunction. Sexual partners. Partner tracing is not required unless screening detects a sexually transmitted infection. Vulval lichen sclerosus. Etiology. Lichen sclerosus or LS is an inflammatory dermatosis of unknown etiology. There is evidence to suggest that autoimmune factors may be involved in its pathogenesis, and recent evidence has shown autoantibodies to extracellular matrix protein 1. There is an increased frequency of other autoimmune disorders in females with lichen sclerosus. Clinical features. Symptoms: itch, soreness, dyspareunia if introital narrowing, urinary symptoms. Other symptoms, for example, constipation, can occur if there is perianal involvement and can be asymptomatic, but this is rare. Signs: pale white atrophic areas affecting the vulva, purpura or ecchymosis is common, fissuring, erosions, but blistering is very rare. Hyperkeratosis can occur. Changes may be localized or in a figure of 8 distribution, including the perianal area. Loss of architecture may be manifest as loss of the labia minora and/or midline fusion. The clitoral hood may be sealed over the clitoris so that it is buried. Complications: development of squamous cell carcinoma, actual risk of less than 5%, development of clitoral pseudocyst, sexual dysfunction, and dysesthesia. Diagnosis: characteristic clinical appearance, histology of vulval biopsy, thin epidermis with subepidermal hyalinization and deeper inflammatory infiltrate. In early disease, histology can be difficult. Management: further investigation. Biopsy is mandatory if the diagnosis is uncertain. There are atypical features or coexistent vulval intraepithelial neoplasia or VIN, squamous cell carcinoma or SCC is suspected. Investigation for autoimmune disease if clinically indicated, especially thyroid dysfunction, for example T4 and thyroid stimulating hormone or TSH, as it is often asymptomatic and has been found be associated. Skin swab, only useful to exclude coexisting infection if there are symptoms or signs suggestive of this. Patch testing is rarely required and only if secondary medicament allergy suspected. The advice of a dermatologist should be sought. Treatment: general advice. Patients should be informed about the condition and given written information. Patients should be made aware of the small risk of neoplastic change. They should be advised to contact the doctor if they notice a change in appearance or texture, for example, a lump or hardening of skin, or if there is a major change in symptoms. Recommended regimen: ultrapotent topical steroids, for example, clobetasol propionate. Various regimens are used, one of the most common being daily use for 1 month, alternate days for 1 month, twice weekly for 1 month, with review at 3 months. It can then be used as needed depending on symptoms. There is no evidence on the optimal regimen. 30 grams of an ultrapotent steroid should last at least 3 months. Ointment bases are much better to use on the anogenital skin because of the reduced need for preservatives in an ointment base and hence less risk of a secondary contact allergy. Alternative regimens: an ultrapotent topical steroid with antibacterial and antifungal, such as Dermovate NN, or generic equivalent, clobetasol with neomycin and nystatin, or an alternative preparation that combats secondary infection, such as Fucibet cream, may be appropriate if secondary infection is a concern. This should only be used for a short period of time to clear infection. Pregnancy and breastfeeding. Topical steroids are safe to use while pregnant or breastfeeding. Topical calcineurin inhibitors are contraindicated whilst pregnant or breastfeeding. Retinoids are absolutely contraindicated during pregnancy and for at least 2 years before. They should be used with caution in females of childbearing age. Onward referral criteria. Those with active disease which has not responded adequately to treatment should be referred to a specialized vulval clinic. Any patient who develops differentiated or undifferentiated VIN or vulval intraepithelial neoplasia or an SCC or squamous cell carcinoma on a background of lichen sclerosus or LS should be seen and follow up in a specialized vulval clinic. Surgery should only be used for the treatment of coexistent VIN or SCC or fusion. Disease tends to recur around the scar. Follow-up. After 3 months to assess response to treatment. Stable disease should be reviewed annually, and this can be done by the general practitioner in those with well-controlled disease. This must be communicated to the patient and GP by the clinic. Patients should be informed that if they notice the development of a lump, sore area, change in symptoms, or change in appearance, they should prompt medical review. Vulval lichen planus. Etiology. Lichen planus is an inflammatory disorder with manifestations on the skin, genital, and oral mucous membranes. More rarely, it affects the lacrimal duct, esophagus, and external auditory meatus. It is an inflammatory condition of unknown pathogenesis, but it is probably an immunological response by T cells activated by as yet unidentified antigens. Weak circulating basement membrane zone antibodies have been shown to be present in 61% of patients with erosive lichen planus of the vulva. In some cases, there is overlap between lichen sclerosus and lichen planus. Clinical features. Symptoms: itch or irritation, soreness, dyspareunia, urinary symptoms, vaginal discharge, and can be asymptomatic. Signs: the anogenital lesions of lichen planus may be divided into 3 main groups according to their clinical presentation. Number 1. Classical. Typical papules will be found on the keratinized anogenital skin with or without striae on the inner aspect of the vulva. Hyperpigmentation frequently follows the resolution, particularly those with dark skin. This type of lichen planus may be asymptomatic. Vulval lesions were found in 19 out of 37 women with cutaneous lichen planus, with 4 of the 19 having had no symptoms. Number 2. Hypertrophic. These lesions are relatively rare and can be difficult to diagnose. They particularly affect the perineum and perianal area, presenting as thickened warty plaques, which may become ulcerated, infected, and painful. Because of these features, they can mimic malignancy. They do not appear to be accompanied by vaginal lesions. Number 3. Erosive. This is the most common subtype to cause vulval symptoms. The mucosal surfaces are eroded. At the edges of the erosions, the epithelium is mauve and a pale network or the Wickham striae is sometimes seen. The vaginal lesions in erosive lichen planus are important to recognize early and start treatment as they can lead to scarring and complete stenosis. The lesions consist of friable telangiectasia with patchy erythema, which are responsible for the common symptoms of postcoital bleeding, dyspareunia, and a variable discharge, which is often serosanguinous. As erosions heal, synechia and scarring can develop. This type is also seen in the oral mucosa, although synechia are uncommon. The term vulvovaginal gingival syndrome is used when erosive disease occurs in these three sites. The presenting symptom is usually of pain and soreness. Complications: scarring, including vaginal synechia, and development of squamous cell carcinoma. In one study, the incidence was as high as 3%. Diagnosis: characteristic clinical appearance. Involvement of the vagina exclude lichen sclerosus. Skin changes elsewhere can be helpful, but overlap between lichen planus and lichen sclerosus is described. Immunobolus disorders such as pemphigus can look clinically similar to erosive lichen planus. Histology of vulval biopsy: irregular sawtooth acanthosis, increased granular layer, and basal cell liquefaction, band-like dermal infiltrate, mainly lymphocytic. Management: further investigation. Biopsy is a necessity if the diagnosis is uncertain or coexistent vulval intraepithelial neoplasia or VIN, squamous cell carcinoma SCC is suspected. Direct immunofluorescence should be performed if an immunobolus disease is considered in the differential diagnosis. Only 25% are classic on biopsy, and clinico-pathological discussion is important. Investigation for autoimmune disease, especially of the thyroid, such as T4 and TSH, if there is any suspicion of abnormality. Skin swab to exclude secondary infection, especially of excoriated lesions. Patch testing if secondary medicament allergy suspected. Whilst a link with hepatitis C and sometimes B has been noted in some countries, there is no evidence of increased incidence in the UK, and routine screening is not thought necessary. Treatment: general advice. Patients should be informed about the condition and given written information. Patients should be made aware of the small risk of neoplastic change. They should be advised to contact the doctor if they notice a change in appearance or texture, for example, a lump or hardening of skin. Recommended regimen: ultrapotent topical steroids, for example, clobetasol propionate. In a study of 114 patients in a vulval clinic, 89 used ultrapotent topical steroids as first-line treatment, of whom 75% improved and 54% were symptom-free. However, in only 9% was there a resolution of signs of inflammation. There is no evidence on the optimal regimen. Maintenance treatment may be required and can either be with weaker steroid preparations or less frequent use of potent steroids. Vaginal corticosteroids. Delivery of corticosteroids to the vagina is not easy. A proprietary preparation containing hydrocortisone, such as colifoam, introduced with an applicator is useful. Prednisolone suppositories may be used in more severe cases. Alternative regimens. An ultrapotent topical steroid with antibacterial and antifungal, such as Dermovate NN, or generic equivalent, clobetasol with neomycin and nystatin, or an alternative preparation that combats secondary infection, such as Fucibet cream, may be appropriate if secondary infection is a concern. This should only be used for a short period of time to clear infection. Pregnancy and breastfeeding. Topical steroids are safe to use while pregnant or breastfeeding. Topical calcineurin inhibitors are contraindicated whilst pregnant or breastfeeding. Retinoids are absolutely contraindicated during pregnancy and for at least 2 years before. They should be used with caution in females of childbearing age. Onward referral. Referral to a multidisciplinary vulval clinic is recommended for erosive disease and any recalcitrant cases or those in whom systemic therapy is considered. Systemic treatments. There is no consensus and little evidence base for the use of systemic agents. In the vulvovaginal gingival syndrome, there is general agreement that azathioprine, dapsone, griseofulvine, chloroquine, and minocycline, all tried empirically, are of little or no benefit. Oral cyclosporine may be considered. Retinoids can be very helpful in hypertrophic cases. Oral steroids are used, for example, prednisolone 40 mg per day, tapered off over a few weeks. Courses can be repeated as necessary for severe flares. The new biological agents have been used in oral and cutaneous disease. Basiliximab has been found to be effective, but its use has not been evaluated in vulval disease. All these potentially toxic therapies need careful monitoring and are best supervised by a dermatologist in the context of a specialized clinic. Follow-up. At 2 to 3 months to assess response to treatment. Active disease should be assessed as clinically required. Erosive lichen planus needs long-term specialized follow-up. Stable disease should be reviewed annually, except in well-counseled patients who control their symptoms well. If review is by the general practitioner, this should be communicated to the patient and GP by the clinic. Patients should be informed that if they notice the development of a lump or change in appearance, they should seek medical advice urgently. Vulval eczema. Etiology. Eczematous and lichenified diseases as classified by ISSVD, includes atopic, the allergic type often seen in people who also have hay fever or asthma, allergic contact, due to skin contact to a substance to which the individual is sensitive, and irritant contact due to skin contact with irritating chemicals, powders, and cleaning agents, and etc. Clinical features. Symptoms: vulval itch and soreness. Signs: erythema, lichenification and excoriation, and fissuring. Complications: secondary infection. Diagnosis: clinical presentation and general examination of the skin to look for other signs of dermatitis. Management. Further investigation: patch testing, standard battery and medicaments, biopsy, only if atypical features or failure to respond to treatment. Treatment. Recommended regimens: avoidance of precipitating factor, use of emollient soap substitute. Aqueous cream should not be applied as a moisturizer due to the risk of irritant effects. Hydromol can be a suitable alternative. Topical corticosteroid. The choice of preparation will depend on severity. 1% hydrocortisone ointment in milder cases, or betamethasone valeriate 0.025%, or clobetasol propionate 0.05% for limited periods if severe or lichenified. A combined preparation containing antifungal or antibiotic may be required if secondary infection suspected. Apply once daily. Follow-up. As clinically required, long-term follow-up and psychological support may be needed. Lichen simplex. Underlying dermatosis. For example, atopic dermatitis, allergic contact dermatitis, superficial fungal, tinea and candidiasis infections. Systemic conditions causing pruritus, for example, renal failure, obstructive biliary disease, primary biliary cirrhosis, and primary sclerosing cholangitis. Hodgkin's lymphoma, hyper or hypothyroidism, and polycythemia rubra vera. Environmental factors such as heat, sweat, rubbing of clothing, and other irritants such as harsh skincare products. Psychiatric disorders, anxiety, depression, obsessive compulsive disorder, and dissociative experiences are often associated with the condition. Emotional tensions in predisposed people, for example, those with an underlying predisposition for atopic dermatitis, asthma, and allergic rhinitis, can induce itch and thus begin the chronic itch-scratch cycle. Clinical features. Symptoms: vulval itch and soreness. Signs: lichenification, for example, thickened, slightly scaly, pale or earthly colored skin with accentuated markings, may be more marked on the side opposite the dominant hand. Erosions and fissuring, excoriations as a result of scratching may be seen, and the pubic hair is often lost in the area of scratching. Complications: secondary infection. Diagnosis: clinical presentation. Psoriasis of the vulva is usually less itchy, and lesions are bright red, often glazed and well demarcated, and frequently involves a natal cleft. History including mental state examination where indicated. General examination of the skin to look for other signs of psoriasis or lichen simplex elsewhere. Management. Further investigation. Screening for infection, for example, Staphylococcus aureus and Candida albicans. Dermatological referral for consideration of patch testing, standard battery and medicaments, ferritin, and biopsy. Treatment. Recommended regimens: avoidance of precipitating factor, use of emollient soap. Some people may have a reaction to aqueous cream when it is used as an emollient. For this reason, it is recommended only as a soap substitute and not an emollient. Topical corticosteroid. Potent topical steroids are required when treating lichenified areas such as betamethasone or clobetasol for limited periods. A combined preparation containing antifungal or antibiotic may be required if secondary infection is suspected. Apply once or twice daily. A mildly anxiolytic antihistamine such as hydroxyzine or doxepin at night is helpful. The symptoms of pruritus often respond fairly quickly to a topical steroid, but unless the lichenification resolves, the itch scratch cycle will remain and the symptoms will recur. A graduated reduction in the frequency of application of the topical steroid is helpful over about 3 to 4 months. Cognitive behavioral therapy may be helpful if there are coexisting mental health issues. Follow up. Mild disease as clinically required. Severe disease, for example, when using potent topical steroids, 1 month then as required. Vulval psoriasis. Etiology. Psoriasis is a chronic inflammatory epidermal skin disease affecting approximately 2% of the general population. Genital psoriasis may present as part of plaque or flexural psoriasis, or rarely as the only area affected. Clinical features. Symptoms: vulval itch, soreness, and burning sensation. Signs: well demarcated, brightly erythematous plaques, often symmetrical, frequently affects natal cleft, usually lacks scaling due to maceration, and fissuring. Complications may be worsened due to Kobner effect by irritation from urine, tight-fitting clothes, or sexual intercourse. Diagnosis, clinical presentation, general examination of the skin and nails to look for other signs of psoriasis. Management. Further investigation. Skin punch biopsy if the diagnosis is in doubt. Treatment. Recommended regimens. Avoidance of irritating factors. Use of emollient soap substitute. Topical corticosteroid. Weak to moderate steroids are preferred, but if insufficient to induce a response, then intensive short-term potent steroids such as clobetasol propionate 0.05% may be used. A combined preparation containing antifungal and/or antibiotic may be required if secondary infection suspected, such as trimovate. Coal tar preparations may be used alone or combined or alternated with topical steroids. However, these preparations can cause irritations and folliculitis. Vitamin D analogs such as talcalcitol, alone or in combination with corticosteroid, however, their usefulness may be limited by causing irritation. Onward referral. Referral to a multidisciplinary vulval clinic is recommended for unresponsive or recalcitrant cases, or those in whom systemic therapy is considered. Systemic treatments, if required for severe and extensive psoriasis, may help genital lesions but not recommended for isolated genital psoriasis. Follow-up. Mild disease as clinically required. Severe disease, for example, when using potent topical steroids, 1 month then as required. Other vulval dermatosis. Vulval intraepithelial neoplasia or VIN. Etiology. This is a vulval skin condition which may become cancerous if left untreated. It is confirmed by histological diagnosis. In genitourinary medicine clinics, the commonest etiological agent is human papillomavirus or HPV. This is known as usual type and is mainly associated with HPV 16. A second type, generally not HPV related, occurs in conjunction with lichen sclerosus or lichen planus, known as differentiated type. The risk of progression to squamous cell carcinoma is much greater with differentiated type of VIN and needs specialized management. VIN is commoner in immunocompromised women. Smoking is also a risk factor. Clinical features. Symptoms. Lumps, burning and itch or irritation, asymptomatic, and pain. Signs. Clinical appearance is very variable. Raised white, erythematous, or pigmented lesions occur and these may be warty, moist or eroded. Pigmented lesions were previously known as bowinoid papulosis, and multifocal lesions are common. Complications. Development of squamous cell carcinoma or SCC has been reported in between 9% and 18.5% of women. Recurrence is common and progression to cancer can occur following previous treatment. Psychosexual consequences have also been described, especially following surgical treatment. Diagnosis. Biopsy. Histology shows loss of organization of squamous epithelium with a variable degree of cytological atypia, which is graded as undifferentiated or differentiated and by depth. Multiple biopsies may be required as there is a risk of missing invasive disease. Management. Further investigation. Ensure that cervical cytology remains up to date. There is an association with cervical intraepithelial neoplasia or CIN. This is probably only applicable to those due to HPV. All patients with VN should be referred for up-to-date colposcopy to exclude CIN and VIN. If there are any perianal lesions, referral for anoscopy is recommended. Treatment. Recommended regimen. Local excision. This is the treatment of choice for small, well-circumscribed lesions as it has the lowest rate of recurrence on follow-up. Imiquimod cream 5%, partial and complete clinical and histological regression has been shown in small studies, but treatment limited by side effects. Only short-term follow-up data is available. This is an unlicensed indication. Vulvectomy. This has been effective, but recurrence may occur and function and cosmesis will be impaired. Alternative regimens. Local destruction. A variety of techniques have been evaluated, including carbon dioxide laser and ultrasonic surgical aspiration, photodynamic therapy, cryotherapy, and laser. There are anecdotal reports of treatment with diathermy. Involvement of skin appendages can occur, and recurrence may ensue if the appropriate depth of treatment is not achieved. The recurrence rates at follow-up tend to be higher than for excision, but cosmesis is usually good. 5-fluorouracil cream may lead to resolution of some lesions, but results are variable and side effects are common. No consensus on usefulness or regimen. This is an unlicensed indication. Supervision. Some lesions will spontaneously regress. This may be the best policy for partial thickness VIN. However, there is a risk of progression and patients should be made aware of this. Pregnancy and breastfeeding. Imiquimod and 5-fluorouracil creams are not licensed in pregnancy. Onward referral. Cases of VIN should be assessed in a multidisciplinary vulval clinic or have input from gynecology regarding assessment for surgical excision. Follow-up. Close follow-up is mandatory, although resolution may occur. VIN 3 particularly has a significant rate of progression. Vulval pain. International Society for the Study of Vulvovaginal Diseases, or ISSVD, defines vulvodynia as vulvar discomfort, most often described as burning pain, occurring in the absence of relevant visible findings or a specific, clinically identifiable neurologic disorder. Vulvodynia is categorized by the ISSVD as generalized or localized, provoked, unprovoked, or a mixture of the two. Localized provoked vulvodynia or vestibulodynia. Etiology. Likely to be multifactorial, a history of vulvovaginal candidiasis, usually recurrent, is the most commonly reported feature. Experimental animal study supports this association. Clinical features. Symptoms. Vulval pain. Frequently felt at the introitus, at penetration during sexual intercourse, or on insertion of tampons. There is usually a long history. Signs. Focal tenderness elicited by gentle application of a cotton wool tip pad at the introitus or around the clitoris. There are no signs of an acute inflammatory process. Complications. Sexual dysfunction, psychological morbidity. Diagnosis. Clinical diagnosis made on history and examination. Management. Further investigation. After exclusion of other treatable causes, no further investigation is required. Treatment. The British Society for the Study of Vulval Disease, or BSSVD, recommends a multidisciplinary approach to patient care and that combining treatments can be helpful in dealing with different aspects of vulval pain. Recommended regimens. Avoidance of irritating factors. Use of emollient soap substitute. Topical local anesthetics, for example, 5% lidocaine ointment or 2% lidocaine gel, should be used with caution as irritation may be caused. The application should be made 15 to 20 minutes prior to penetrative sex, and washing off the lidocaine just before sex or the use of condom by the partner can reduce the risk of transfer, resulting in penile numbness. Oral contact should be avoided. Physical therapies. Pelvic floor muscle biofeedback, vaginal transcutaneous electrical nerve stimulation or TENS, vaginal trainers, cognitive behavior therapy. Alternative regimens, pain modifiers. The benefit of drugs such as tricyclic antidepressants, gabapentin, and pregabalin is not clear. Amitriptyline gradually titrated from 10 milligrams up to 100 milligrams according to response and side effects may be beneficial in some women. Surgery. Modified vestibulectomy may be considered in cases where other measures have been unsuccessful. Patients who have responded to topical lidocaine prior to sex have a better outcome. Follow-up as clinically required. Long-term follow-up and psychological support may be needed. Unprovoked vulvodynia. Etiology. The etiology is unknown and the condition is best managed as a chronic pain syndrome. Clinical features. Symptoms. Pain that is long-standing and unexplained and may be associated with urinary symptoms such as interstitial cystitis. Signs: the vulva appears normal. Complications: sexual dysfunction and psychological morbidity. Diagnosis: clinical diagnosis made on history and examination having excluded other causes. Management. Further investigation. After exclusion of other treatable causes, no further investigation is required. Treatment. The British Society for the Study of Vulval Disease, or BSSVD, recommends a multidisciplinary approach to patient care and that combining treatments can be helpful in dealing with different aspects of vulval pain. Recommended regimens. Use of emollient soap substitute. Pain modifiers. Tricyclic antidepressants are well established in chronic pain management. Few studies have specifically examined the effect in vulvodynia. However, amitriptyline is frequently first-line treatment. Dosage should be increased by small increments, starting at 10 milligrams up to 100 milligrams daily, according to the patient's response. Note: a recent randomized study has not confirmed the beneficial effect of amitriptyline. If unresponsive or unable to tolerate the side effects, gabapentin or pregabalin may be used. Alternative regimens. Topical local anesthetic, for example 5% lidocaine ointment or 2% lidocaine gel. A trial of local anesthetic may be considered, although irritation is a common side effect. Cognitive behavioral therapy and psychotherapy, and acupuncture. Follow-up as clinically required.